So this is lecture 2 for genitourinary and the urinary system. We're going to look at elimination and the anatomy and assessment of this system. So let's get started. This is just some theory and clinical practice things that you should know. Even though for my class it's not less than 29.1, but it was for another class that I did. But this information is pertinent to any book we're using, to any class on this system. This will help you, hopefully, with the information that's provided. So it breaks down the theory, it breaks down the clinical practice. I'm not going to read it to you, you can read it for yourself. So let's talk about our structure of the urinary system. Kidneys. We should have two kidneys. Now, there are people out there that are born with one kidney. We also have people out there that have a kidney that can actually, they can lose their kidney due to infection, to the injury, different things like that. So the kidney is two bean-shaped organs. They're approximately 6 centimeters wide to 12 centimeters long. If you're not sure about what size that is, get out a ruler and look, just put your fingers on how 6 centimeters by wide and 12 centimeters long they are. They're located at the level of the L1 on either side of the spine. So this is important to know where they're located because people with different kind of kidney infections or kidney issues, stones, different things like that, they're going to have pain in that lower back area. And so if somebody's saying, oh, that part's hurting me so badly, and they start to point into that area, it should hone you into thinking that's possibly something going on with their kidney or the renal system. Nephrons. This is a biggie, guys. Inside each nephron is a glomerulus consisting of a cluster of capillaries surrounded by the Bowman's capsule and a system of tubules. Now, do I want you to memorize what a nephron is? No, but what I want you to do is understand that we have 1 million nephrons in each kidney. And why this is important is one thing, as we age, those nephrons will start to decrease. They just start to kind of die out and go away. So we have less nephrons. The nephrons are the working unit of the kidney. They're the filter, guys. The glomerulus is the filter. This part is what makes the filtering happen, that pulls the toxins out of the body and gets rid of them through urine. So it's important to understand we've got nephrons. They contain a glomerulus because we're going to learn about glomerulonephritis. We're going to learn about some other diseases and issues down the road. But for right now, just understand what it is. It's surrounded by a Bowman's capsule and a system of tubules, but it's the working unit of the kidney. It's the filter. So we want to make sure that you understand that because there's drugs that also will affect different parts of the kidney. And so we want to make sure that you kind of understand the anatomy a little bit. So in this structure, we have ureters. They're hollow tubes that carry urine from the kidneys to the bladder. Each ureter is about 25 to 30 centimeters long. Why is that important? Well, because first of all, if there's a blockage of a ureter, that means there's somehow what's coming from the kidney to the bladder can't get there, right? That's a problem. And what can happen is then fluid can back up into those kidneys and drown the kidney literally. So we want you to kind of understand that and think about the anatomy. The bladder is a hollow muscular organ located in the lower pelvis that stores urine. That's what the bladder is. And so just so you know, the bladder is a stretchy muscular organ that's located. So it stretches as it fills and goes back in when it empties. So it is definitely something that's pliable, it's hollow, and it stores urine. The urethra is what carries the urine from the bladder to the meatus. It's flow controlled by urinary sphincters. And then we have the meatus, which conducts urine to the outside of the body. Now, after I've said all that, I want you just to kind of look at this picture. So here it is in the body. So we have the kidneys. As you see, they're bean-like shape. We have kidney beans that we put in chili. Look the same kind of coloring. Those sit up. Have you noticed how where it is? Look at the spinal cord. And then up there you have the two kidneys, and they're kind of protected, and they should be based on that lower spinal rib cage area. They're right in there, and we're trying to protect them. We have the ureter. It comes down, as you see, from the kidney to the bladder, as it was described. We have the bladder. It's right here sitting down in the pelvis, and then the urethra that goes from the bladder to the outside. The meatus is right there, and that's what opens and the urine can come out. But I like visuals. So it helps me to read that stuff and then kind of look at the picture and get what's happening. So if I have a blockage um, in the urethra, that would be from the bladder to the outside world. If I have a blockage from in a ureter, that means I'm having somehow urine's not able to get from the kidney to the bladder. Do you see what I'm saying with anatomy? So that's why it's kind of important to understand that. So let's take a look at this. This is the track of the male urethra. The previous slide was a female. So you saw how kind of short the urethra is. That's important to note, and I'm going to talk about it here in just a second. But let's look at this. The male has the bladder. It's still there in the pelvic area. It has the prostate, though, and this is important to understand because the prostate, if the patient has a benign prostatic hypertrophy or BPH, this can get so enlarged that it can impede flow. So we can have issues if we have an enlarged prostate. So that's important to know. Prostate cancer, if we have any of that, and you'll learn that later when we talk about cancers. But this is the area. So whenever you think about that, this is where it's located. And it can cause problems with emptying of that bladder for males. Now, the urethra is this very long, look how long it is. It goes all the way down the penis, out the urinary meatus. By saying that, females is very short and males is really long. So this is a sterile system, the bladder. If I have a short route from bladder to outside world, then compared to this long route of outside world to bladder or bladder to outside world, women are more prevalent to UTIs because of that. Their anatomy makes them more prevalent to UTIs based just on that piece of anatomy alone. So let's just talk about the actual function. Kidneys, they filter blood through the nephrons. You need to understand that because when damage comes to nephrons or to the kidney, it's going to affect the nephron, and that is our filtering. We cannot filter. If we can't filter properly, we can't pull the waste out and get rid of it. It's going to alter what is filtered out and what comes out. Think of it this way. Have you ever had a strainer and it doesn't have big enough holes to strain, or you've put something hot in and it's melted some of the holes or altered it and you just don't strain as well? That's what kind of happens with the kidney. If there's damage done or something, you're just not going to get it. It's going to take a long time to filter it. It's going to impede filtering, so things won't run through it like we want. But the nice big filter, one of your strainers, if you put that in and it's all ready to go, it's brand new, it's got big open, nice, you can pour your spaghetti in it and the water just comes right out, right? But if you have a little one that can't hold that much, or you put more in it than it's supposed to, that kind of stuff, it's a slower process because it's smaller holes or it's damaged or whatever. Kind of think of that as we're thinking about filtering things running through something. There's other analogies we can use, but that's the one that just came to mind. Metabolic waste and excess water are extracted. That's what happens in the kidney, and that's why we create urine. regulate electrolytes by excreting excess amounts and help with acid-base balance, retaining hydrogen ions and bicarb. I have that in here. We will go into depth on that come Monday of next week for my class in fluid and electrolytes, but it's there because that's what the kidney does, and the kidney plays one of the most important roles when it comes to fluid and electrolytes in our body and homeostasis. So just kind of make a note of it because you're getting ready to see it again, folks. Tubules secrete, excrete, and reabsorb electrolytes, water, and other substances, and that is what the function of the kidney is. What you need to remember about the kidney too is it receives 20 to 25% of the blood circulating um, in our blood supply. So that's a good amount of blood, guys. It comes down, it's going to pull and do these things with our blood. It receives that much blood. The nephron is composed of 3 parts, just so you know. The nephron has a proximal tubule, the loop of Henle, and a distal tubule. And we'll look at that a little bit more, and I want you to understand that there's a proximal tubule, a loop of Henle, and a distal tubule. Why that's important to know, guys, is things take place in different parts of the actual nephron. So if I give Lasix or furosemide, that drug, because I want to diurese them, pull fluid off of them, it's going to take or affect my loop of Henle. It actually is a loop diuretic. So it's going to pull the fluid or do what it needs to in the loop of Henle. And that's important to understand because if you think about it, if it's proximal, it's above, there's a proximal tubule, it's higher than, right? Loop of Henle's right there in the middle, and then your distal is down. If I have something that takes place in that middle piece, it's in a prime piece of a lot of things that happen with the kidney. So if that's the case, then it's going to work faster. It's going to do different things. There's more going on in that loop than what goes on in the proximal because that's the beginning, that's the upper piece. Then, and the distal is things have already happened in the loop. So when we get down there, things are different, if that makes sense. So by understanding there's 3 parts of the nephron: proximal tubule, loop of Henle, and distal tubule. And I know somewhere, if it's not in this PowerPoint, there will be one in this next week that I post that's in my fluid and electrolytes about this, and we'll talk about it more. Also, just so you know, if you remember in anatomy, when we started talking about in anatomy and physiology, you talked about kidneys are involved in renin production. This is important also to know because we're going to affect, there's different things we do for the patient or disease processes that affect renin production, and that can affect what's going on with our patient. Everything that's collected in the distal tubule is what becomes urine. So we have our proximal tubule, the loop of Henle, and then our distal tubule. So it's almost like a process. Number one, it's going to go through the proximal tubule, and this is going to take place. Then we get to this loop of Henle, and this is what all takes place in the loop of Henle. And then when we get to that distal tubule, whatever's left, whatever's been filtered, whatever, that's what's going to create urine and what will urinate out. So that's why I want you to kind of understand that. Okay, let's look further into the function of the urinary system. So kidneys manufacture approximately 1.5 liters of urine every 24 hours. Usual urine output is between, for adults, 30 to 70 milliliters per hour. Now, I'm going to tell you something. The rule of thumb, the golden rule, write it in your notes, highlight it, put it to memory. If you make less than 30 milliliters an hour of urine an hour, you are in trouble. That is renal failure. We are in trouble. The kidneys are shutting down. So if you have less than that, you should immediately call your physician or the practitioner that's following your patient and let them know this because this is an issue and a problem. So, but on average, 30 to 70 an hour. So if you add that up, right, it will add up to more. When we look at trends with nursing, so I'm looking at blood pressure, all my vital signs trending. Am I always at this pulse rate? Am I always close to this blood pressure? Trends are important because they paint the picture of what we see. So same with I's and O's. So let's say 1 hour I have 35 milliliters out. I have a Foley catheter in and I see 35 milliliters for the hour. But the next hour I have 60 milliliters. And the hour prior to the 30, I had 70. I'm not going to jump on board and call the physician and say, hey, I've got 30 milliliters out, right? Because I have others. So I will trend that. But if I start to trend downward, let's say I'm on average putting out 50 milliliters an hour in a Foley catheter, and I'm looking at that, and then all of a sudden it's 40 an hour, and then I'm down to 30. I should be calling a physician way before I drop under 30 because I'm trending down. And the question is why? Why am I? Is this a traumatic thing going on with the body? Are our vital signs unstable? Are we in a crisis? Are we shutting down, a system, the cardiac system or the respiratory system, something going on that's affecting the body? Then we need to be on top of it, right? You don't want to be at the end of it because then you're not going to be able to help salvage the kidneys and save your patient. Um, Ureters carry urine from the kidneys to the bladder. So by understanding that, if we have any kind of blockage, stones, different things like that, that can actually cause a blockage, then we need to understand that because it can affect the kidneys. If I block it, like I said earlier, then I can flood the kidneys with urine and actually kill our kidneys. It will destroy our kidneys. So ureters actually empty by gravity. It's a peristaltic movement. It just kind of, there's no sphincters. It just kind of pours from the kidney down into the bladder. It just kind of motions itself down into it. And that's kind of an interesting thing to understand. Um, when the bladder, it stores the urine and it'll signal into the brain when it's full. So that's why you get the urgency to go. So people lose that urgency, and that's an issue depending on what's going on. They lose the ability to control sphincters, all of that. When we get down, it's a sphincter control to open up and urinate. So if that's the case, different strokes and paralysis, things like that, that's why these people are incontinent. They have no control of bowel or bladder most of the time. The bladder will empty when 250 to 400 milliliters of urine is present. It's under voluntary control. So what happens is our kidneys filter everything. We start to store, right, in that distal tubule. Whatever's left is going to become urine. It pours, it's in the kidney. It'll come down, it'll fill into the bladder. And when we get to about 250 to 400 milliliters, we'll get an urgency to go. It's time to go urinate. Now, sometimes people will deny or say, no, I'm not going to go. I've got to hold it, got to hold it, got to hold it. So the body is made to then remind you. It'll remind you again. It's still filling, just you got to remember that. It doesn't stop the urine from coming down and filling in the bladder. So it will continue to fill. And then, you'll get another urge to go. Then usually by the third urge, people, if they don't go, will end up urinating on themselves because eventually it's got to give and you have to empty it. You want to. But the thing that we have to understand is that when we have a Foley catheter, or if we have, it's going to continuously drain. That's why we monitor usually hourly for Foley catheters on urinary output. But let's say all of a sudden, they go to the bathroom and you're measuring it and they have 250 out. And then the day goes on and they don't have an urge to go. They don't go to the restroom. They don't go to the restroom. They don't go to the restroom. They're becoming distended. So their bladder becomes full and you can almost see it. If they're thin enough, you can see it. You can palpate and understand they're distended. They have a distended bladder. It's tender, or it hurts to kind of palpate it and touch. They feel discomfort with it, but they can't seem to get it from the bladder out. And so that is an issue and a problem. And so we would need to understand how much we should make an hour, How much should we make in 24 hours? And then if someone doesn't urinate in 16 hours, that's a big, huge problem. In 8 hours, it's a big problem. We should be going to the bathroom, every 4 to 6 hours, people go to the bathroom. Sometimes people can hold it longer, and it also is affected by our intake. So if we're not drinking anything and we're not taking IV fluids, then it's going to decrease our urinary output. So it all kind of goes hand in hand, guys. I could stay on this forever, but I'm not going to. We're going to move on because there will be more answers to this here in just a second. Okay, so the bladder can contain up to 1,800 milliliters of urine. Average urinary output is 1,000 to 1,500 milliliters per day. That's what we see. Remember, that's an approximate 1,500. 1.5 liters. There's a conversion for you. Urethra carries urine from the bladder sphincter to the meatus. We've already said it. The internal sphincter relaxes with micturition, urinating reflex. So our internal sphincter will relax when we start to urinate. It's a reflex. The external sphincter is under voluntary control. Okay, so at least 600 milliliters of urine must be excreted per day to remove waste products. So if we're in a renal bind, or we have renal disease or injury or something that's causing us not to be able to filter like we should, or not to have the fluid or the blood volume that we need, then we have to have made at least 600 milliliters of urine to get the daily waste removed from our bodies. And this is important to understand, because if we can't do that, what happens to the waste? It stays in the body. It stays in the body, and we continue to keep it there floating around, causing us problems. Our body will do everything in its power to maintain homeostasis, maintain this normalcy, as we could say, or within normal limits. We try everything. And so if we can't have 600 milliliters of urine in a day, and so some of those toxins and stuff stay in, electrolytes, whatever, then we're going to have issues with fluid and electrolytes. We're going to have issues with other things in our body. It's going to affect things based on this alone. So that's why it's kind of important to understand. Talking about the bladder and how the reflexes are, if we have something that has disabled the spinal cord, if we have paralysis or a spinal cord injury or a stroke, anything like that neurologically that would be an influence to our sphincters or actually controlling things in our body. If that's the case, then what happens is we become incontinent, or we can have bladder retention. So it'll go one way or another. We'll either not be able to control it if we can still urinate, and then if we can't control the sphincters that are there that we can open and close and need to open and close, our body can't do it because of a neurological insult, then what we have to do is cath those patients. So paralysis patients, spinal cord injury patients, they will do in and outs on them throughout the day. Now, side note, just make a little side note. If I have to do catheter in and out on a spinal cord injury patient throughout the day for the rest of their life, because they'll never get this back, the injury is done. If that's the case, what are they most prevalent or prone to have? A urinary tract infection, because we're going from outside in, constantly introducing something into a sterile system. The bladder, the genitourinary system, is a sterile system. It doesn't like anything from the outside to come in. And so they'll be or prevalent too. The other thing is if they're holding on to urine and it's not coming on down the system like it should, and it's sitting in the bladder for periods of time, it will start to grow things. So we have to be very, very careful with these patients and be really on top of, are they having a UTI? Because guess what? If they can't feel it, if they're paralyzed, let's say from the waist down, and they've lost all that control, and it's starting and they're having to be cathed, they're not going to feel burning upon urination. They're not going to feel the signs and symptoms of a UTI. Do you see how it's going to start to come into play for this, that when we have these issues, what we can see? And we'll learn as we go along. You will learn in nursing school different disease processes and things that affect the system. And then we see the outcomes. Okay, this is just different things that can block the ureters. Stones, and people will reduce kidney stones, and we talk about them. There's different ones out there. They're made by different things in the body. This is a different lesson, but just so you know, the stones can cause blockages. That's why it's so important if people are prevalent to having kidney stones, they need to, if they feel it or if there's something going on, we have to be very careful because they can have blockage. And what does that do? It blocks the urine from coming down from the kidney to the bladder if we're blocking a ureter. Remember your anatomy. Tumors in the abdominal cavity, trauma to the lower abdomen, disruption of the bladder by tumor or trauma, enlarged prostate I mentioned, trauma to the urethra, infection of the urinary system, and neurological damage. And we've kind of covered those things. So just take a minute and think about it. Put those down and then piece that where it should go. Neurological damage is when we have the issues with paralysis, right? We have an interruption of their neurological piece of the spinal cord, all those nerves and stuff, the connection to that. Brain activity, different things. Trauma, notice that disruption of the bladder by tumor or trauma. So one of the biggest things is if a patient has a car accident, we have seat belts that go across the waist, right? So what happens is one of the things when they enter into an ER, they're going to take a actual I can't think of the name of it right now, sorry, but almost like a bladder scanner, it's the same kind of thought. And they're going to take a look to see if the bladder is intact, because what happens is people go forward and the seatbelt will catch them and it can actually rupture the bladder or cause damage to the bladder. And we need to know that. That's part of the trauma screen, is looking at the bladder. So let's talk about what happens when the aging client occurs. What happens to the renal system? One of the things is they'll have a decrease in number of functioning nephrons. Remember how many nephrons I told you we had and what they do? They're the working part of the kidney. They filter, right? So decrease in the filtration rate. We're going to have a decrease. Remember, with aging, everything decreases except for wisdom increases. Decreased bladder tone. They'll have nocturia where they get up and have to go to the bathroom at night frequently. Decreased bladder emptying, so they have increased residual that can cause UTIs and other infections. Enlargement of prostate, it can cause urethral obstruction. Remember that actual slide that has the anatomy, go back and take a look at it. And then incontinence is not a normal part of aging, so we need to understand that. There are a lot of products out there though that we can help a client with incontinence. It just depends on what's going on. The previous lecture on elimination talked about all the different kinds of incontinence. So this is an interesting slide. Normal urinary elimination. Infants void 5 to 40 times a day. Just depends. Remember, change that diaper, change that diaper. They have no control. Preschool children may void every 2 hours. Adults void 5 to 10 times per day. Males will void about 300 to 500 mLs and females about 250. Average output should be approximately 30 milliliters an hour. Now, that isn't like, if you've got 30 milliliters an hour, I mean, kind of do the math, right? So if I have 30 milliliters an hour and I take that and I multiply that times 24 hours in a day, it's approximately 720 milliliters in a 24-hour period. So if you do the math, that's what you get. So if you go back to that slide, if we don't put out at least 600 milliliters of urine in a 24-hour, we don't get all the toxins out. So 30 is the golden number, guys. Take it to memory, take it to life. Any patient that does not have 30 milliliters of an hour of urinary output, they are in trouble. That is a call the physician. This is not good. things are not good. Okay, the kidney is dying and we need to intervene as soon as we possibly can. However, the patient can die actually if we're not careful. So there are factors that affect. We've talked about a lot of these. Neurological muscle development can affect normal urination. Alteration in spinal cord integrity, that would be your spinal cord injuries. Fluid volume intake, if we don't drink enough, if we don't take enough volume in, it can affect our normal urination. We'll have a decrease in urinary output. Fluid loss and perspiration. So we're starting to see people, let's say we're an athlete, we're out running, right? Wouldn't be me, but those out there that do that, if you sweat, 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 and you don't replace that volume, it can affect our normal urination. It'll shut down. We won't put out as much urine. Vomiting, diarrhea, of course, those are all volume losses. This is all volume involved, these last few that I'm talking about. And then we have the ADH secreted by the pituitary. So antidiuretic hormone is ADH. It influences our fluid balance. And it's something that we learned in anatomy and physiology. It's the dreaded, do y'all remember it? But it is important to understand that it changes in the fluid osmolality of the blood. So what happens is, by saying that, if we have a decrease in volume, then the ADH determines how much that we should absorb or not absorb. So it's a hormone that controls volume in our body. Let's just leave it at that because we're going to break that down a little further as we go along. So let's say a patient is vomiting or having lots of diarrhea. So that is a volume loss, right? If that's the case, what happens is the body goes, "Ooh, we don't have enough volume. We need to release ADH. We've got to release this hormone so that we can start to absorb more volume back into our body, maintaining homeostasis once again." So by saying that, if we have a loss, ADH is released. If we have an overload or we increase our fluid, it will be suppressed because that allows for more urine formation and diuresis to take place. So if I'm losing volume, I need it because it's going to help me absorb up volume. And what I'm trying to do with volume is maintain a blood pressure, maintain life. So that's why it's so important that we have this hormone, and it does this. If I'm overloaded though, I don't want it to keep sucking up like a sponge more volume into my system. I need to be getting rid of volume. So what happens is it'll suppress it. The body will suppress the release of it, and then we'll start to urinate out more. It'll start to be filtered out through our urine, and we'll be able to urinate or pee it out. So one of the things that we need to look at when you're starting to document, when we're in the clinical setting and we're documenting about genitourinary system or urine, we want to know things. We want to know the color of it. It should be straw colored yellow, a yellow. It can be a little lighter if there's more fluid in it, a little darker, or an amber color if we don't have enough, volume, if we've decreased our volume intake. But normally it's straw colored or an amber color. Clarity, it should be transparent. It should be clear. Clear yellow urine is what we want. It should be clear, guys. There shouldn't be things floating around waving at you. It does say or only slightly cloudy. Well, sometimes you might have someone, and it could be just something that comes on as it's coming out through the system if they've given you urine specimen, or there could be something that might make it slightly cloudy. But normally we want transparent or clear urine. Odor, it has a faint like ammonia smell, and I'll be honest with you, urine, if a patient is hydrated or you're hydrated and you urinate, you don't really smell urine. It doesn't have a very strong smell. It's after it sits on something. Let's just say like if you have a puppy or a kitty cat or something like that and they urinate on the carpet. If you don't clean it, at first you don't smell it, but give it a day or two and it's going to get that ammonia smell and it's going to get stronger because the diluent, the water part of it's going to evaporate and then what's left in there is going to smell. But you really shouldn't smell people's urine like an abnormal or an odor smell that's pungent. It's not a bad smell that you smell. It shouldn't be. If you do, there's something going on. Speaks volume. So really there shouldn't be an odor, but they might have a faint odor of ammonia. Specific gravity, the normal range, and you do need to know this, is 1.010 to 1.030. That's specific gravity. And we will go further into what specific gravity is in Monday's lecture. But it's important to understand. Long time ago, we used to test specific gravities on the floor, and we'd put the urine and we'd take this thing and we'd spin it, and it would let us know what the specific gravity was on it, this little device. And I'll never forget doing that. And I was thinking, how accurate is this? Now we send it down to lab, and lab will give it to us, and they run it through a machine. pH for urine is slightly acid. It's ranging from 5.5 to 7.0. These numbers will vary based on books. So for my students, we love to use the ATI product. So those numbers are what will stand for you, just FYI. But I think it was 5.0 is what it is for ATI, but we want it around in that range. So if I take the pH paper and I put it to urine, I should get a pH about right in here. I'll know it's slightly acid, and I should be able to know gauged on a color where it runs in. So when we do those dipsticks, we can kind of look at things like that. Just so you know, it's slightly acid. The pH ranged from 5.5 to 7.0, but normal pH for blood, and write this in your notes because you're going to need to know it, is 7.35 to 7.45. That is your normal pH for blood. Okay, and we need to understand that. So our body will constant and continuously try to do everything in its power to maintain this blood pH of 7.35 to 7.45. And in the meantime, the rest of our bodies should be doing different things. For our bladders and our urine, it should be slightly acid with a range. And I want to say ATI says 5.0. I might be wrong, but go back to your books for my students. Make sure you use those numbers. But on average, it's 5.5 to 7.0. So next thing we have anuria. So we know that it's where we're not making urine pretty much. If that's the case with anuria, it's less than 100 milliliters of urinary output in 24 hours. So there might have a little bit of urinary output, but it's 100 milliliters in a 24-hour period. We already did the math. If we do 30, we have 720 in a 24-hour period. So they're pretty much making absolutely no urine, and some won't even have this amount. So anything less than 100 or to 0 in 24 hours is considered anuria, and yes, you need to know it. Dysuria is painful or difficult urination, and it may be from an infection or trauma. So if you're in your note writing world, this is where it takes place. These are the terms you need to use. If a patient is having dysuria, then we know they're having painful or difficult urination. Incontinence, of course, is involuntary release of urine. Bottom line. So more terms that you need to know and understand that you will see. Nocturia, that's when a person has to get up more than twice in the night to void. And honestly, we don't usually intervene on that unless it's more than 4 times. If they get up 4 or more times in the night, then it's time to maybe intervene and do something. It says when they get up more than twice. So if you get up once in the middle of the night and go to the bathroom and maybe one more time before morning, not a big worry. 3 times, we're pushing it, but when they get to doing it 4 or more times, it's time to either take medications or do something to help with this situation. Oliguria, decreased urinary output less than 400 milliliters in 24 hours. These numbers you need to know, guys, because there's a difference. If I say anuria, it could be less than 100 or less. If I say oliguria, it's decreased urine output less than 400 milliliters in 24 hours. Polyuria is excessive urination. and that's greater than 1,500 milliliters in 24 hours. So I put a little star note down here for everyone so I can just make sure I don't get blown up by my students or by anybody else out there in the world, is that the numbers vary slightly based on different textbooks and different presentations, but it should be in those ballpark numbers. It's not off by 1,000 milliliters. It might be off by 50. But these are numbers that I think are quite accurate, and pretty much I've looked at several books and are the same across. But if you come across something, don't freak out. For my students, the numbers come straight out of their ATI information. Okay, next is cystitis. Anything itis is inflammation, just FYI. So if you see an itis out there, you know what, something inflamed somewhere. It's inflammation of the bladder, cystitis. It may be caused by an irritation of highly concentrated urine, bacteria issues, injury, installation, or irritating substances. They'll have symptoms of cystitis: frequency, urgency, dysuria, which is difficulty or painful urination, burning malaise, foul smelling urine. They're going to have something that's not a slight ammonia smell, and slight temperature elevation. So they're going to have a little bit of an elevated temperature. When we see an infection, then usually we see an elevated temperature, because what is the body trying to do? Homeostasis. And it's going to raise the temperature to try to kill if there's a bacteria or something in there that's causing an infection or an issue. Okay, so let's look at specimens. So what we can do is we send any voided specimen needs to go down to the laboratory within 5 to 10 minutes. Anything after 15 minutes is there could be a change in its characteristics, meaning it can be either altering or changing, and your results will be altered or will be altered, and you will not get accurate information based on what you're sending for your patient or on your patient. Midstream clean catch, just think of it this way. You need to clean for women front to back. We wipe front to back always. Do not forget that. Teach your clients and patients that. Sometimes it can be difficult for patients to do based on their size, or if they have arthritis or something going on that they can't move to do that. So we need to think about it and what we can do to help them. The midstream clean catch. So we will clean front to back for females. Men will clean around the outside of the penis there from the meatus down. And then we're going to start to urinate. They need to start to urinate and then put their cup to catch the urine at that point for the specimen. It's a midstream. So they're already urinating and we're going to catch it. It is clean. Think about it this way. Once you start to urinate, anything on the outside, if when you're first starting to go, it's going to have those germs and things that are on the outside of the body going in with that urine. So once we start, that's cleansed out, and what's coming is a good specimen. Specimen from an indwelling catheter, just remember, you put a catheter in, you can get the specimen immediately from the bag but after 10, 15 minutes, you cannot. So if you can't get your specimen that fast after you put it in and finished everything, then you need to obtain it up through the port. Most catheters, indwelling catheters, have access up at the top part where you inflate the balloon and the catheter is attached to the actual tubing for the bag. What you do is you pinch off the tubing going down towards the bag, and so the urine will stay up in that upper part of the Foley. Clean, clean, clean around the port, and then you're going to access through that by drawing off in a syringe your specimen from the indwelling catheter. Always remember to release your bag so that then the urine will start to flow back down. If not, you're causing an obstruction, and then urine's going to stay in the bladder, causing problems with the bladder and some other things. So always make sure you stop that. Undo that rubber band or undo the little thing so that you can have free flowing urine into the specimen bag. That is the best way. Go back through that. There is a lesson on that, on how to obtain a specimen on indwelling catheters. Sterile catheterization specimen. If we have a patient we need to get a sterile specimen from, it's an in and out catheter. We want to make sure we keep our sterile procedure, sterile field. We set everything up. It's an in and out catheter. It will go in. You have a container that is sterile that it comes in, and then you will just allow the urine to flow into that container, and then you will put that urine, still sterile, into a sterile container, closing it down and sending it to the lab. 24-hour urine specimen, we do not use the first specimen of that. Go back through those steps. We toss that down, get rid of it, and then the 24-hour urine, the containers are on ice. They need to be put in like the bathroom. That usually takes 2 to 3 containers for a patient for 24 hours to collect their urine. So we just keep putting them on, making sure that they're there. And once it's complete, we send all containers together down to the lab. You don't send them piece by piece. When one fills up, you don't send it down. It stays as a whole and then goes down, and then they can run their test on it. The other thing with 24-hour urine specimens, please make sure that you label the containers. It is so important that a label is on every container. Any specimen you collect, urine, blood, whatever, sputum, it needs to have a label on it. But if we're holding something and it's going to be multiple somethings, we definitely want the label so that we don't lose a container. And we also number them. So 1, 2, 3, or 1, 2, or whatever. So first container, second container, third container. Strain specimens. If we're straining specimens, what you want to do is anybody that has had a kidney stone, this is rule of thumb, you want to put a hat. If we want to gather urine to put into anything, in a urine specimen, 24, if they're using the bathroom, you have a hat and you're going to catch it. You want to catch it in the hat, and then we'll just run it through the strainer. Hopefully seeing if there's any stone or anything that we can send to lab to be tested for what kind of stones. Also, we want to know, did they pass their stone? Because if they have stones, and that's what we're looking for in that strainer, if they're passing it, we should have no problem with urination. Things should be resolving, pain should be resolving, and we know that they're moving. If they're not moving, then we're going to have to be concerned. The physician will need to be notified that we've seen nothing, and our concern would be obstruction from the stones. So it's important. And we teach our patients to do this, guys. They can go home and do this. If they've got stones, they'll go home, but we need to teach them to give them a hat, let them catch it, and give them a strainer. There's a way to strain it. They can flush the urine when they're straining urine. We're just looking for what's in the urine that's large enough to catch in a strainer. So here are different urine collection devices. The one in the back there with the white, that is a hat. Do you see it has actual numbers that are aligned? That's what those little things are going down. That's what we have urinate. You can measure how many milliliters are in that. You can see that you can pour it out the back. It's got a little nip, so you can pour it into whatever. But it's important to put it so you catch the urine. You can also use these to catch feces. So if they have to have a bowel movement and you need a fecal specimen, you can put it towards the back of the toilet and they can actually defecate into that to catch you don't get it out of the toilet, you get it out of that. You have a urinal. We have a fracture pan. That's the pan to the left with a kind of narrowed down flat piece. Those are excellent to slide under a patient. They're so much easier. But I'm going to say this to you. If you have a patient that needs to have a bowel movement, if you have a patient that's going to urinate a whole bunch with a bowel movement or just urine, you might want to use the full bed pan. That's the bigger pan there because it actually holds a lot more. So that's a nursing judgment. More terms to lose. These are more terms to lose. These are abnormalities found in urine. Glycosuria is glucose in the urea. You should not have sugar in your urine, period. Protein you should not have in the urine, proteinuria. Hematuria is blood in the urine. There shouldn't be blood in there. Pyuria is pus in the urine. And ketonuria is ketones in the urine. And we test for these. Sometimes there's reasons why they spill over into, and we understand why. We'll have pus if we have infection. We can have blood if we have infection. If we have proteins and glucose, things like that, there can be things going on with blood sugars, diabetes, and ketones too. And one of the things we do is we do the keto diet, don't we? That was a big thing. So people would pee on a stick, and that shows us how many ketones are on the stick. And if you're in ketosis, it means the body's eating itself. That's why you lose weight. And so that was always a proof that you were truly in ketosis, is if you could pee on the stick and it was a dark purple. So there's ways that we test it, but these are abnormal, should not be in the urine. we should filter and do what we're supposed to and hold on to these things. They shouldn't spill out. So, assessment. Patients should be assessed for usual pattern of elimination, incidences of any incontinence or frequent urination. If they're having to urinate every 15, 20 minutes, every hour on the hour, there's an issue and a problem. We need to talk about it. Now, if they're taking a diuretic, they're going to. So you need to understand that. Burning upon urination is not a normal. We need to assess that. So if we're talking to our patient, we're going to want to ask them, do you have a sense of urgency? Do you have any burning or pain upon urinating when you go to the bathroom? What's your usual pattern of elimination? And they can say, well, I go about every 2 to 3 hours. I have to go. I usually don't have frequency, that kind of stuff. We want to establish a baseline, and then we want to know what's going on, because then we can see if it's abnormal or not. Senses of urgency, time of the day for elimination. If they're only urinating at night, they have nocturia. That's an issue and a problem within itself. And then our total daily fluid intake. So if a person doesn't drink all day and then they get home from work at 5 or 6 o'clock in the evening and they start pouring liquids, they drink, 4 glasses of iced tea, which is full of caffeine. And if they have it with sugar, it has sugar. And those things affect our urgencies to go to the bathroom. They're also putting more fluid in the body. So what is going to happen? We're going to have to get up and go to the bathroom throughout the night. So what would we tell our patient if that's the case? We would want to say, hey, let's just hold and maybe not drink the tea at night. Try to drink earlier in the evening. Cut yourself off at a certain hour, and maybe get more fluids in during the day, and not as much all slammed into you in the evening. So do you see where I'm going with the thought process? Those are the thoughts you should have. But these are part of your assessment. So definitely review those, because when you get in the clinical setting, you're going to want to assess these things. So a question, the urinary system is made up of which of the following structures? This is just kind of a look back of what we've already talked about. The answer is number 1, ureters, bladder, kidneys, and urethra. The rest is not part of the system. Prostate is not part of the system, but it's right there. So it can cause problems if it enlarges or there's any issue with the prostate. A urostomy, guys, is a test, right? It's not a test, I'm sorry. It is actually an ostomy, from where we pipe the ureters down and out of the body so that the urine comes out into a bag. Excuse me for that error. Um, Bladder, kidneys, urinary meatus, but a urinometer is not a part of the system. It's a measuring tool. So Erin's patient's been complaining of burning when she urinates. Her doctor ordered her urinalysis, which shows pyuria, a term you should know. These results indicate what? The answer is number 4. There's pus in the urine. That's what pyuria means. So she's been having burning upon urination. They send her urine down and it shows pyuria is present. They have pus in the urine. Pus in the urine means usually that there's bacteria present in the bladder or the kidneys, and that's a part of infection. So there's an infection going on. Just so you know, proteinuria is protein in the urine. Bilirubin in the urine suggests liver disease or obstruction of the bile duct. Hematuria is blood. Remember those terms. We just had them earlier. And add things to it. So when we're looking at bilirubin in the urine, that's not a norm. And bilirubin is deals with the liver, and it's a liver disease. So just so you know. So I'm not going to read all of these, but I want you to look at this, because we use a Foley catheter, and that's what we learn to put in. That's what we see. But there are other catheters out there, just so you know, and there's some of the other catheter types that you'll see. Foley is our most the one that we use frequently and we see all the time. Coude catheters are a harder type rubber with a little kind of formed turn to the end, and they're easy to use. They're a little more strict. They don't give as much. And what we can do is put those in with people with enlarged prostates, because what happens is we can then control it and help it pass through that part of the prostate that's occluding the ureter, making the ureter smaller. There's others there, Malacot, there's condom casts, and really what needs to be added to this, and this dates the slide, is that we have PureWicks now. We don't even have indwelling stuff. We can use PureWicks. Condom casts are for men, but they are now coming out with some type of, like a PureWick. It's a pouch, and you just put the male's parts in that pouch, and the urine just collects in a bag in it. So, and it goes to suction. It like goes down into the bag, and the bag will then be sucked out to the wall. It's kind of like a PureWick for men, which is a good thing because condom caps are really difficult. They don't stay on very well. They're a real pain in the bottom. Literally. Bum, bum, bum. Specimen types, we have routine, midstream, indwelling catheters, sterile 24 hours, strain and inserting the catheter. So those are all there for you to look at. So these are different. This is a single lumen urinary catheter, straight with a rounded tip. That's kind of what we see when we're doing a Foley. Malacot tip is a retention catheter. We see we have this. There's a reason for that. Mushroom tip is the DePez or retention catheter. Lots of times when we start to see these, you're either going to be working in that specific area, physician's office, or in, like you're working with a urologist. But sometimes urology will have to come in and use these different catheters. They're not something that we normally find or insert ourselves, but they are out there. So those that I just showed you, they're single. They just go in, there's no balloon. And pediatric patients, younger children, very young, they do not have a balloon. You do not blow up a catheter in a child, a very small child. As you learn pediatric nursing, you'll know exactly the ages and all that, but I do want to make that clear. This is a double lumen, and this is where we see the Foley catheter. As you see, it's a single coming out with a hole, just a round tip going in, but the balloon is blown up here. You have two ports that go to it, and as you can see, drainage, sterile water, one's for the balloon and inflation, and one's for the urine. So that's what it looks like going on down. That your sterile water goes into the balloon so that it holds that Foley catheter or that catheter in place. So this is just a good picture to kind of show you. So there are some times that we will have a triple lumen catheter. And these catheters are set up so that we can put the catheter in. We'll have water to inflate a balloon, a port so we can inflate the balloon. Then we're going to have a port that we can irrigate the catheter. The whole point is this is in a sterile system. So we don't want to break a sterile system to do a bunch of things, because all we're going to do is create infection for our patient and cause more harm. So this is set up where we have a drainage system, an irrigation system, and then a port. So you have three ports, and the third port is for the balloon, which helps keep it inflated and in place in the patient. Excuse me. So there's different positions. The ideal position for putting in a catheter, a Foley catheter or a catheter, is supine, on their back with their legs in a frog-like position, a lithotomy position. And so this is a sideline position though, so it is possible. I want you to look how they are on the side and how you can access them. We do that if a patient is unable to get into the supine position and put their legs up. So you can put them on the side, put their leg up if they're possible. It's a more comfortable position, and it is a position of choice, but we prefer supine. It's the easier and better way to access, but just depending on what's going on. So just always kind of think about it. But supine is the choice of the golden choice. That's where you want them on their back in a frog-like, legs up in a frog-like position. Suprapubic catheters, we will see these sometimes. We are not going through the actual meatus and up into the bladder. Instead, we are going through the front part. You see the symphysis pubis there? That's the front of the pubic. That's the pubic bone. It's up on top above that, if you can see. And it's an actual surgical incision. And what happens is the tube of the catheter will come down and sit into the bladder, and it comes straight out and then into the collection bag. There's a reason behind this. I had some major surgery done and had to have some female surgery done down here, and my physician put a suprapubic catheter in me for post-op care. It was awful. I will not lie. Every time I turned in the bed or anything or moved a certain way, the catheter would scrape the wall and I could feel it, and it wasn't pleasant. But this is the picture with the anatomy of a suprapubic catheter. We did a whole thing on incontinence. I'm really not going to go through that entire thing, but I do want to show this, that it could be temporary or permanent. We're worried about skin integrity, as I said. We risk of infection from some body image disturbance. We talked about that. It's, people really start getting upset if they can't control bowel or bladder. The next thing is, though, is what can we do? It can be corrected by surgery. So for women, they can have bladder slings, they can do prolapse repair, different things like that to help that. But Kegel exercises, and yes, men and women can do Kegel exercises. And so we'll talk about Kegels a little bit more, but you want to know what Kegel exercises are and how important. So we actually use and start to increase that pelvic floor strength. So that will help with the incontinence piece. So there's different ways you can engage those muscles and hold and let go. You can do it while you're driving. You can do it, any way you want. It's not so easy. Sometimes people will be going to the restroom, urinating, and then they'll engage those Kegels and stop urination and hold for a minute and then let it go. That's a strengthening technique. And there's actually people out there that really do and work with women and men, but mainly women have a lot of issue, and they will do things to help with uh, pelvic floor strengthening and teach them how to properly do Kegels and other things. So urinary diversions and care necessary when the bladder is removed or bypassed. This is when one or both ureters are implanted into the abdominal wall. That's a urostomy. So we have colostomies, ileostomies, that all deals with the bowel. This is what deals with the bladder, the kidney and the bladder. So if I have bladder cancer and my bladder has to be removed, I would have a urostomy for the rest of my life because the bladder's gone, and they're going to uh, uh, take those ureters and implant them in my abdominal wall, creating an ostomy, a urostomy. They have a pouch that goes on, it just collects urine, and then just have to empty it. It's very irritating to the skin. Urine continuously around the edging of that wafer, those seem to stay very irritated and broken down for people that have them in comparison to ileostomies and colostomies in the bowel piece. So they can also do this surgery where it can be diverted and into the bowel if needed. And a pouch can be constructed from a piece of bowel to create something for them also. So it just depends on what's going on. Most of the time what we see is the urostomy for folks, but there's other things out there. And the biggest thing for the diversions is skin care, skin care, skin care. They can be temporary and they can be permanent depending on what's going on. The other thing that you need to think about or concentrate on with a patient with a urinary diversion is their mental state, right? Body image. They have an insult to that based on what they're seeing. Any kind of ostomy, that is a big thing. And lots of times we see these urostomies or colostomies, ileostomies with younger people. They're still out there working. They're still out there having life. They still have spouses and children and all of that stuff. And so they can have really severe depression and body images disturbances based on this. So we need to always remember that and focus in. There's a lot of really neat things out there, guys, that they can use to cover. I was sharing with a student the other day, I was able to do my master's clinical in an ostomy clinic with a wonderful ostomy nurse, Shirley. She's fabulous. She's the guru. But Anyway, what was so interesting is a lot of females with Crohn's disease have to have ostomines. And this is not a urostomy, this is dealing with bowel. But they have like lacy things that you can put up over the bag, the pouch can go down in it and then it can cover. And so it's pretty. And so if you're still sexually active or you still want to engage in that, you can actually cover it. You don't have to worry about some bag flapping off that looks, so sterile, or a clear bag and you see a big red, beefy red ostomy staring you. It's not exactly what you would want in those situations. So there's different things out there to support these folks. We need to plug them in. As the nurse, you plug them in. You're that person. You're the patient advocate, and you need to make sure it happens. Let's make sure we document what we need to. When a patient voids normally, voiding sufficiently, whether there's a problem, is there dysuria, anything like that, and anuria, oliguria, all those good terms that I told you need to know, whether the patient is continent or incontinent, the amount of your urinary output. If you're not measuring it, it's void times 1, times 2, however many times. Any bladder irrigations, if you're doing anything to irrigate a bladder, we need to document that because we need to know what goes in and what comes out, always. Presence of an indwelling catheter, and when it's removed. This is one thing that nurses seem to overlook. They'll go to take out the catheter really quickly because the patient's going home or the patient's going out to the floor or something like that, and they'll forget to document that it's been removed. But it's important that we tell them that it's been removed. If we do any catheterizations on patients, we need to explain to them that when we go to remove it, they're going to have this feeling that they need to go to the bathroom. And that's normal. It's an urgency. Like, oh, I got to go, but then they don't really go. Also, we need to let them know when they go for the first time after the Foley or the catheter has been DC'd, they might have burning upon urination, and that is normal. First time. If they continuously have burning upon urination, that is not normal. That would be considered a sign of probably a UTI. So a urinary tract infection. So we want to make sure we explain these things to our patients so that they understand, because if not, they don't know what's going on and it can be detrimental to them. So for my students, I had told them there would be no math unless absolutely told there's math. So here's an actual math question for you that you might see in testing for us. Brenda is making rounds on her post-operative patient. She notices their patient's Foley has drained 90 milliliters in 3 hours. Which statement is correct? Okay, answer 2 is correct. This is an average amount of urinary output. If you divide 3 into 90, we get 30 milliliters an hour. And is it okay to have 30 milliliters an hour? Yes. Anything under 30, we're calling a doctor. But, and the little but is in practice, if you've got somebody only putting 30 milliliters out in an hour, we need to be concerned. Okay? So, but in a question like this, another but is that 30 into 90 is 30, and that's okay. Another question for you. Aaron's patient will be going home with a catheter. All the following are true regarding a Foley catheter, except all are true except number 3. The balloons are inflated on Foley's 5 to 10 milliliters fluid, never 15. One of the things I want to really stress with you is you'll see that people that have had Foley catheters for a long period of time, things start to erode in there and get bigger. So catheters can slip out. The balloons will come out even and inflated. And so one of the things that nurses will do, they'll start to leak around their Foley, stuff like that. They'll go ahead and put more fluid in that balloon. That is not what we're supposed to do. That is not evidence-based practice. That is not a good practice for nurses to do. If that is the case, we need to talk to our physician, maybe have urology involved, and maybe they can do something else or use another catheter that does hold more fluid. But on average, it's 5 to 10 milliliters, and we don't want to add any more fluid. But what is true because you got to look at the keyword except. We're looking for a false there. Read your question carefully and what is it asking? So what is true in these answers, it is the most common type of indwelling catheter. That's a Foley. That is true. It does have 2 lumens. One lumen is to inflate the balloon and one lumen is for urine to come through. It's a drainage tube so the urine can come down and into the bag. And the other thing that is true in this is it may also be used for a suprapubic drainage. And yes, so if someone has a suprapubic catheter in, it's usually a Foley catheter in that hole with the balloon inflated to hold it in place. So we can deflate the balloon, take it out, and if it's going to be a long-term situation, change it and put another Foley catheter into that suprapubic catheter, suprapubic uh, a hole for them opening. So you can put that in. It needs to be put in sterile technique always. Any Foley catheter, anything in a bladder, anywhere, anything with a genitourinary system, it is sterile. Anything with the GI system, it is not sterile. Fecal matter is not sterile ever. So, last question, guys. Let's do it. Bruce's patient needs a condom catheter. This type of catheter is used when? The correct answer is in a male incontinent male. Number 4, a male is incontinent. If a patient cannot void, it means they can't get urine from the inside out, something that's on the outside, because a condom catheter goes on the outside. It rolls up just like a condom that we use on men. It's the same premise, but there's a tube that connects to it. You can connect it to a bag and collect the urine. It isn't for females because of that, right? If they cannot void, we need to put something inside to drain the bladder because they're unable to put it out. And it is not, anything female should never be involved with a condom catheter. We have PureWicks for females, but like I said previously, they've got a new thing out for males. It's kind of the same preface as a PureWick for females. It is where you put the actual men's genitalia into like a bag, a clear kind of bag looking thing. Penis goes down in that. And also it's bigger. So it comes and it's going to actually not attach to the penis itself, but to the skin or to the abdominal, like lower pelvic area there against them flat. You stick it there, it connects to suction on the wall. And so they just urinate just like in the PureWick, and it'll just kind of suck the urine and put it up there into the container. It's a great concept or thought. I think it's awesome because condom catheters can be a real bear. They don't want to stay on. They don't stick well. If you pull on them at all, they'll loosen up. And it's hard for men sometimes when they're moving in bed. They can get pulled off and all that. And then you have a wet bed and all that. So it's a thought, but those are the questions. And this is a broad overview with some more information that is needed for elimination for the genitourinary piece. And so I really hope it helps.